So next I call upon Dr. G.S. KALAIMATHI for her topic, Firecracker Injuries and Occult Globe Rupture. She's working as a consultant at Giridhara Institute, Kochi.
Good morning, everyone. My topic is on firecracker injuries and occult globe rupture. Ocular injuries due to firecracker work accounts for 14% of the firework injuries, and 65% of all firework injuries are to the bystanders. Ocular injuries are due to three effects: mechanical, thermal, and chemical. The mechanical is due to the pressure involved due to the ejection. And what is it is made of? It is made of cardboard or plastic. The propellant is a black powder, which is potassium nitrate, which is dangerous to the eye, and its other ingredients are magnesium hydroxide, charcoal, sulfur, and lithium. These are poisonous to the respiratory tract and irritates the eye, nose, throat, and skin. The chemical injury overlaps with the thermal and mechanical injuries. The magnesium hydroxide causes devastating injuries, both thermal as well as chemical. It penetrates the eye deeply. The mode of injury is 51% is because of the misuse behavior, and 31% is because of the device failure. So mechanical eye injuries can be divided into closed globe and open globe. I am not going to go to the details. The range of firecracker injuries, it ranges from the superficial foreign bodies to the open globe injury, traumatic cataract, etc. So initially we have to manage the full thickness corneal and scleral injuries. So we have to image to rule out the intraocular foreign body, and decision making has to be done whether to do the cataract extraction in the as a primary procedure or a secondary procedure, and wound exploration has to be done to look out for any foreign body or any other tear. And if the lid edema is profuse, then we have to examine the patient under general anesthesia. And if the corneal foreign bodies are multiple and at multiple different levels, then we have to remove only the superficial foreign bodies, and the deep-seated foreign bodies can be left alone. So the management of the firecracker injuries can be dealt in four headings. First is the ocular surface management, eyelid management, glaucoma management, and the posterior segment management. The ocular surface management, we follow the Duos classification, and it takes into account the limbal ischemia and the conjunctival involvement. If the limbal ischemia is less than 6 clock hours, then the prognosis is very good. And if there is total limbal ischemia, only then the prognosis is poor. In between, with 6 and 9 clock hours, we can always give a good to guarded prognosis. The initial management consists of the vision testing, copious irrigation, the removal of all particulate matters, doing a double eversion with under topical anesthesia, and topical steroids for 10 to 12 days. And it should not be given beyond 2 weeks because of corneal melting. And white eye is an ominous sign. And if the scleral ischemia is extensive, then we can go for a tenonplasty. And if there is persistent epithelial defect, it means that there is loss of stem cells. Then in that case, we can go for amniotic membrane grafting. And if there is spannous formation, we can go for SLIT, that is simple limbal epithelial transplantation. In that case, we have to remove the pannus, place the AMG, put the limbal tissue from the fellow normal eye, and stick those limbal tissue with glue, fibrin glue, and place the BCL. In case of if the stroma is involved, then we have to go for lamellar KP and AMG. And if it is a severe injury and if the eye is moist, then we have to go for Boston Cape Pro. And if the eye is dry, we have to go for osteoodontokeratoprosthesis. And coming to the eyelid management, eyelids are usually protected by blink reflex and Bell's phenomenon. So the ocular sequelae is because of the post-burn eyelid deformities. So the initial examination is important before the edema sets in. So examine for the periorbital skin and for any eyelash losses. The first degree burn involves the epidermis, so there won't be any deformities. The second degree burn involves the papillary dermis, so there will be dermal fibrosis leading to ectropia. The third degree burn will involve the reticular dermis, so later on ectropion and lid shortening can be there. And full thickness burn will involve the subcutaneous tissue and muscle, and that can be contractures later on. The complication of eyelid injuries can be lag ophthalmos, exposure keratitis, trichiasis, and entropion. So the management involves stabilizing the patient, examining the globe, irrigation of the wound, removing the dirt and sloughed skin, sweeping the fornices with moist skin tip applicators, and trimming the burnt eyelashes with ointment covered scissors. So broad spectrum systemic and topical antibiotics should be given, and antibiotic eye ointments can be applied over the eyelids. Preservative free lubricants can be used, and topical povidone iodine ointment can be used for the face. And if dressing is needed, lubricating dressing with serofoam gauze can be used, and Pseudomonas is a common infection in such conditions. Surgical interventions are lateral canthotomy and cantholysis in case of orbital compartmental syndrome with high IOP and APD, suture torsorrhaphy with bolsters, or surgical torsorrhaphy can be done. The lag ophthalmos can be reduced by releasing the contractures, and lacrimal system should be taken care of in the early stage by daily punctal probing, and in late stage by punctoplasty, canaliculoplasty, and canalicular stenting. In late stage, we have to manage the ectropion, and eyelid grafting is needed in very, very bad cases, and management of the sequelae. Coming to the glaucoma management, glaucoma can occur both in closed and open globe injuries, and it's more common in closed globe injuries. The common tissue injuries during firecracker injury is iris sphincter tear, iridodialysis, angle recession, cyclodialysis, trabeculomeshwar tear, zonulodialysis, and retinal dialysis. In closed globe injury, the high IOP is because of inflammation, hyphema, subluxated lens, and dislocated lens. In low IOP is because of hyposecretion, TM tear, cyclodialysis, and occult globe rupture. So check the IOP with GAT or eye care, and we can defer the gonioscopy for a week. The increased IOP because of inflammation and hyphema can be managed with steroids, cycloplegics, and anti-glaucoma medications. The subluxated anterior lens can give rise to secondary angle closure glaucoma. So YAG PI should be done immediately, and elective lens removal should be done. Dislocated anterior lens is an emergency because it can give rise to corneal decompensation. So lens removal should be done under mannitol. Glaucoma due to open globe injury occurs later. So if the meticulous repair is done in the initial and during the primary repair, and if good AC reformation is done, we can avoid this glaucoma formation. And overall, glaucoma is initially managed medically. If not under control, then we have to go for trabeculectomy or tube or cyclodestructive procedures. Anyway, lifelong follow-up is needed for such patients. Now coming to the posterior segment management, first maintain the integrity of the eyeball, then go for the posterior segment surgery. Orbit PA view is mandatory for medico-legal cases. Then CT scan for the exact location of the foreign body should be done. MRI can be done for non-metallic foreign bodies. In case of cyclodialysis, it can be sutured to the sclera. Prophylactic intravitreal antibiotics can be given to prevent endophthalmitis. And if you see something like this 360-degree subconjunctival hemorrhage with chemosis, then we have to suspect posterior scleral perforation. In that case, we have to do 360-degree peritomy and suture the perforation. So to conclude, the prognosis depends on the severity of the injury, and it needs multiple specialty to manage. The education of the public and children on firecracker safety and first aid is necessary. Prevention is always better. Wearing protective eyewear, wearing cotton clothes, purchasing crackers from legal manufacturers, and keeping fire extinguishers ready at hand. Thank you.
Thank you, Madam. Madam, normally for firecracker injuries, do you always do CT orbits to rule out intraocular foreign bodies?
Yeah, it
What is
depends.
the normal protocol?
Yeah, it depends. Initially, it all depends upon how severe it is. But it's always better, at least just, orbit X-ray is a must.
The problem with these the firecracker injuries are that the entry wounds may be very small, so you can get intraocular foreign bodies without much of an external entry wound. So it's always better to do a CT orbit, I think, for medical legal purposes also, so you don't miss anything.
Yeah.